welcome to ATCM. Today we're going to discuss a case about one 58-year-old male who came to our ER with complaints of abdominal discomfort, breathlessness with fever for past 3 days. Shall we begin, ma'am?
Yes.
So, patient initially came with severe abdominal discomfort. And
What is the age of the patient?
58-year-old.
Okay.
So initially patient was conscious oriented and was obeying to command. In primary survey, the error was patent and there was no pooling or secretion, and he was able to talk normally and complete one full sentence. In breathing, but the auscultation, chest bilateral air entry was equal, and but the thing was he was having severe tachypnea, respiratory rate of 50 per minute. The saturation of 95% was maintained in 10 liter O2. So initially itself following the circulation, but the peripheral pulses were felt normally, and the pulse rate was 125 per minute and BP of 140 over 100 mmHg. In GCS Glasgow scale, GCS was full and pupil was equally reactive, and initially the temperature was normal at that time.
So in this patient, what all things are abnormal? Patient is having elevated respiratory rate, and patient is having desaturation, and patient is having tachycardia. Okay.
Tachycardia, yeah. So in adjuncts, we did with the ABG. ABG was showing pH of 7.43 with PCO to 45 and bicarb of 30.
Okay.
And other than that,
was it taken with O2 or without O2?
It was taken that time. It was without O2.
Okay. PO2 is very less, but saturation is not corresponding to patient saturation. Okay. Anyway, PO2 is less. Lactate is okay. Okay.
ECG was showing tachycardia features. No other STT changes are noted.
Okay. So what will be the differential diagnosis? Elderly person coming with abdomen distension, breathlessness, fever.
Fever, abdominal discomfort. So pneumonia can be an initial differential diagnosis as a patient.
Pneumonia, whether there will be abdominal complaints.
Severe pneumonia or
lower zone pneumonia can present with abdominal pain.
Discomfort and pain. So other than that, abdominal distension can be associated with some cholecystitis, cholangitis, pancreatitis, and other than that, patient sometimes.
So it can be pancreatitis along with the pleural effusion. Okay.
Yeah. Then patient sometimes can.
If patient is coming with any loose stools followed by respiratory complaints.
Atypical pneumonia
can be there. Okay.
Can be there. Then patient can have some myocardial infarction can also mimic the complaints of chest discomfort with breathlessness.
Okay.
And
is this patient a known case of CLD or anything?
Not a known case of CLD.
Yeah. So if this patient is having low albumin levels, there can be abdomen distension ascites along with pleural effusion. That can be attributing to the hypoxia, abdomen distension and all. Okay.
So further investigation, the main will coming to the secondary survey. He was a 58-year-old male with the comorbidity of varicose vein, came with complaints of abdominal distension for the past 1 week, which was gradual in onset and which was progressive in nature, and what was associated with low-grade fever, which was in intermittent episode, and cough was there with expectoration of sputum, and associated breathlessness. He also complains of constipation since the past 2 days, and for the same patient was evaluated outside in a hospital. But as the symptoms worsened, he was referred to our hospital for the further management. In allergic history, no allergies was noted, and other than that, events are same as mentioned above.
Okay. So complaints is like more than 5 days, almost 1 week history is there.
Yeah.
Then along with cough, shortness of breath is there. So can this patient be in ARDS? He is having elevated respiratory rate is there. Okay. What is the X-ray findings? I will go to that. Okay.
X-ray findings, the thing is that bilateral pleural effusion was noted.
Okay.
Right greater than left.
Okay. No much infiltrates or anything?
No. Bilateral scattered infiltrates was noted. Other than that, X-ray was kind of normal.
Okay.
So
you ruled out ARDS also?
ARDS was normal. So further, we were on examination. Patient is on palpation, mild tenderness was noted over the hypochondrial region, and on further evaluation, general examination was kind of normal only. Other than that, tachypnea and saturation, low saturation.
So in this patient, what all things will you do in the bedside?
Bedside, for the same as patient is having
So
severe
patient,
tachypnea.
we have a patient here. This patient is having abdomen distension, breathlessness is also there. So bedside, we if suppose our X-ray is not available, or if the CT machine, whatever investigations possible is not available, like some blood investigations are already available. If the X-ray machine is complained, what all things we will be doing in portable ultrasound machine?
Can do portable ultrasound can be done, which can find out if at all there is pleural effusion, or if at all there is any abdominal collection, free fluid, or any abdominal hemorrhage.
Okay.
We can rule out these things with the USG, portable USG,
Okay.
and then we
So
can.
he's having tachycardia, increased respiratory rate. So in the echo, what all we'll do, we can check the LV
LV
functions can
function.
be checked. Then we can do the IVC, that can
yeah.
be done. Then we can rule out any pericardial effusion or tamponade if anything is there. Then the lungs, we can look for the lung sliding
sliding.
effusion can be checked. If you are seeing some C lines or anything, that can be pneumonia. So that all things we can do. And in the abdomen, we can look for any free fluid or ascites if anything is there. Okay.
And further, we did the routine lab investigations, wherein which the total count came out to be elevated. 32,000 was the total count, and the CRP was on the higher range, 238. Procal was also elevated to 57.
Okay.
And the other
What
main
is the platelet value?
platelet value was 2 lakh.
2 lakhs. So he is having elevated total counts. CRP is elevated, procalcitonin is elevated, and platelet is somewhat normal. Okay. Other electrolytes are normal.
Within normal limits, but the D range, LFT and RFT was rearranged. OTPT was 360 or 250, and bilirubin total was 10, and direct was 7.8. Other than that, the creat was 2.29.
Okay, okay. So he is in sepsis. Can it be hepatitis?
Hepatitis, but the OTPT is not
It
that
should be
much
more than
significantly
1000.
elevated.
So something is affecting the liver and the kidney.
Kidney,
Okay. So can he be in Wheel syndrome?
Wheel syndrome was initial one of our initial differential
Differential
diagnosis. We sent for the leptospiral IgM, lepto IgM was also sent, but came out to be
Negative.
negative.
So in view of this, we suspected that
Yeah,
also.
also,
So other than this, what all investigation should we do?
So we can do the bedside ultrasound, and X-ray can be taken.
So you told X-ray there was only some pleural
pleural
effusion was
effusion,
there.
yeah.
Okay.
And then ultrasound was taken, and
Other than this blood investigations, what all should we say? So this patient is in sepsis. So what else should we do? Procal is anyway elevated.
so
It is most probably a bacterial infection.
So we will be starting initially with the antibiotic therapy, followed by
So first
culture
1 hour,
will be.
what all should we do? First 1
Initial
hour.
1 hour itself, if the patient is in a septic shock, we will initially start with the antibiotic therapy with the blood
If
cultures.
patient is in sepsis, we will have to place 2 large bore IV cannulas. Then we should take blood cultures. Then we should start with high dose antibiotics should be started. Then we should check the initial lactate value. This patient's lactate was only 1.9. So if it is more than 2, then we will have to reassess the lactate after giving fluids. And if this patient is in shock, we should manage with fluids, and if at all not improving, we should start on vasopressors. So this patient is in sepsis. So here, since he is not having any elevated lactate or he is not in shock, so this patient we can we will have to take blood cultures, to large bore IV cannula, and antibiotics. Okay. So what antibiotics should we start here?
So we can start the patient in empirical antibiotic therapy. As the patient is having the chest symptoms as well as abdominal symptoms, we can start with the fluoroquinolones, or cephalosporin can be done.
Okay. What was started in this patient?
So this patient, as the patient's CRP was high, with Procal also in the higher range, we started with the meropenem, and further unfolding when we did the USG abdomen. So USG abdomen was showing multiple collections over the left lobe of liver.
Okay.
So following it, we also started with metronidazole.
Metronidazole. So we are suspecting an anaerobic infection. So we started on metronidazole also. Okay. So in this patient, we are what all blood cultures were sent?
So blood culture, aerobic and anaerobic blood culture was sent
So
along
this
with.
patient, especially since we are suspecting some collections in the liver, so something else is also along with aerobic, we should send anaerobic blood cultures also. Okay, then.
So following it, we did the multi-phase CT with the contrast, and it was showing multiple collections in the left lobe of liver. Like left lobe of liver was showing multiple collections.
Okay.
So and also the largest collection was also size of nearly 7 centimeter, and also small collection was noted in the right lobe of the liver also, but that not that much significantly a lot. Minimal collection was also
So
noted.
looks like a liver abscess.
Liver abscess.
So usually where all liver abscess will come?
Liver abscess can occur in the right and left lobe of the liver.
Mostly it will be in the right lobe. Why?
More blood supplies
To the right side. Okay, so mostly it will be on the right side. So if it is in the left side, what things we should suspect? Either it can be because of a direct infection to the left lobe, if this patient had a recent bowel surgery or anything, or if there was any biliary leak or peritonitis, it might be because of that. Okay, otherwise liver abscess as such can be hematogenous spread or direct spread. Okay, so left side we saw these findings. Okay, what might be the organism causing this one?
So usually the organisms can be E. coli, Klebsiella, or else if at all it's a single, you can be Endamoeba histolytica, which usually occurs as a single collection. As we have multiple collection, we didn't know the culture report.
Multiple collection can be because of Staphylococcus aureus also. Then this hydatid cyst, these things can also happen. Okay, so what might be the, so we have a patient, 56-year-old male patient who presented with with some random complaints, and at present we diagnose it as having liver abscess. Okay, so what might have precipitated this liver abscess? Is he having any other disease like immunocompromised or anything?
He was not having the diabetes or immunocompromised, but his HbA1c came out to be 7.2.
So undiagnosed diabetes is there. Then is he having any cirrhosis? Anything?
No cirrhosis features was not.
Is he alcoholic?
Occasional drinker, but not daily or weekly, like occasionally.
Okay, so so immunocompromised, diabetes mellitus, these are some of the risk factors, and recent surgery, these things and all. So we have a size of 6 centimeter, 6 into 7.3 into 8.3 centimeter size is there. Okay, will the difference, will the size, according to size, whether the management varies?
Yeah, according to size, the management varies. If the size is more than 7 centimeter, surgical drainage of the lobe is advised. And also, if it is in the left lobe, there is high chance it can get into a rupture.
Yes.
So, surgical drainage is the most advised form for the same.
The thing is, if it is like this patient, if this patient is coming with a size of more than like, okay, if this patient is having a size more than 6 centimeter, along with the patient is having cirrhosis ELD features, there is high risk of what? Rupture risk is there. Rupture risk. That is one complication we will have to anticipate. So this patient is occasional alcoholic, no much CLD features, so that is not there. Okay. If the size is more than 5 centimeter, and if it is single uniloculated, we how can we manage this one?
Can pigtail drainage if at all the patient is symptoms are persisting.
Okay, so we can draw drainage. Suppose same patient uniloculated but less than 5 centimeter.
Medical management will be.
Medical, or we can just aspirate the conduct. Aspirate, okay. If it is more than 5 centimeter or whatever size, multiloculated, multiple loculations are there as this patient, we need to suspect Staphylococcus aureus, so gram positive coverage should be done, and this is mostly requiring surgical drainage or laparoscopic drainage. Okay. So this patient comes into this category. Okay. Then how did you proceed with this case?
Further, we did the UST guided pigtail aspiration was done. And following with his symptoms improved, and his CRP and the lab parameters began to come down.
Okay.
And
So, suppose this patient is coming to us, we incidentally diagnosed as this one. Will you start antibiotics initially itself?
before diagnosis or after?
Suppose we incidentally found that this patient is having liver abscess. Will you start antibiotic that time itself?
Yeah.
Thing is, ideally, in this condition, we will have to start antibiotics because patient is in sepsis. There are features of liver, renal failure, everything. So this patient is sepsis. So first we will have to start antibiotics, then drain this abscess. Then we will have to send what are gram stain and culture of the abscess collection, and then we will have to change the antibiotic depending on this one. Okay, but if this patient is stable and there is no signs of sepsis, we can wait for the culture reports and then start on antibiotics. Okay, so liver abscess, empirical antibiotic, we started meropenem and metronidazole. What other antibiotics we can give?
We can give fluoroquinolones,
Fluoroquinolones,
cephalosporins,
third generation cephalosporins. Then we can give ampicillin, gentamicin, metronidazole, or we can give fluoroquinolones with metronidazole can be given. Okay.
So you see the pigtail insertion and drainage was done, and the collection was sent for the culture also. And the blood culture and the collection, both pus culture came out to having E. coli.
Okay, okay.
And it was sensitive to meropenem. We already started, and we continue with the same antibiotic.
Okay.
And his symptoms began to decrease, and his breathlessness, tachypnea reduced, and also abdominal distension and the discomfort along with the pain reduced.
Okay.
And
if it was like hydatid cyst and all, can we drain like this?
hydatid cyst had to remove the cyst.
We should remove it surgically, otherwise it will rupture and it will cause severe peritonitis and death. Okay.
And following with his pigtail drainage was monitored daily, and we did the repeat CT because after 1 week also drainage was coming, and repeat CT was showing a minimal collection only. Other than that, his symptoms reduced. All symptoms began reduce.
Okay.
And for further over the next course of days, his drainage became zero, and removed the pigtail also.
Okay, okay.
Symptoms all reduced, and he symptomatically became better.
Okay, okay.
Here the most important thing had to look forward is that had to differentiate between the amoebic liver abscess and the pyogenic liver abscess. Mostly amoebic liver abscess will be caused by Entamoeba histolica, whereas in pyogenic liver abscess is usually caused by the Klebsiella, E. coli, then Staphylococcus, then other than Streptococcus also cause the same. In amoebic liver abscess usually seen in low-income countries in a age group, younger age group, whereas in the pyogenic liver abscess usually in older age group.
Okay.
And other than that, amoebic liver abscess is usually single, can be multiple, but usually single. The pyogenic will be usually multiple, and usually seen in diabetes or any immunocompromised state, and also in gallstone implantation can occur. And the other thing in amoebic liver abscess we have to look for is it will be the when we drain the same, it will be looking like an anchovy sauce or anchovy paste. Whereas in the pyogenic liver abscess, it can be pus drainage with like a pus drainage appearance. Necrosis can be seen in the same. And
Amoebic abscess also, if we drain, it is very risky. That itself can cause peritonitis. So if at all, if it is, if we are suspecting amoebic cause, like if there is any travel history or like that, and if we are suspecting amoebic abscess, ideally go for a surgical treatment.
Then blood cultures and the diagnosis system is that we can go for the PCR antigen testing, serology for the amoebic liver abscess, and usually antibiotic therapy with the surgical correction will be needed. Whereas in pyogenic liver abscess, drainage will be the most apt choice usually.
Okay, okay. How is the patient now?
Patient symptomatically improved, and he became stable, and we discharged the patient.
Okay, okay. Thank you.